Meyer. I'm your webinar host, and I'm the managing director of the Essential Tremor Education Center. Now, we've still got a lot of folks joining us. We've got over 100 folks already on, and we know that there's another 100 or so that are joining right now. And so rather than getting right into Dr. Caplet's presentation, we're going to spend the next couple of minutes just getting acquainted with Dr. Caplet. We're going to chat with him for a little bit, and probably in about 3 or 4 minutes, we'll get into the true content of the webinar. But thanks so much for being here. Hope you'll enjoy this next couple of minutes with a little chat time with Dr. Caplet. Dr. Caplet, tell us how old you were when you made a decision to be a neurosurgeon, and why did you make that decision?
Well, that might give away too much private information. There are federal laws against protected health information, because then I'll give away my age. But I was, it's funny. I was not one of these people that was born, deciding that I was going to be a neurosurgeon. I'm the director of our residency training program here at Cornell in Manhattan, and I see all these applicants who say that since they were 3 years old, they want to be a neurosurgeon. That wasn't me. I was actually a scientist. I was doing a lot of research as an undergraduate at Princeton in viruses and things that in those days were very relevant to cancer. And I thought I might become a cancer scientist and maybe a general surgeon, because I was always interested in the surgery, doing, say, cancer surgery or something. It was really in my second year of medical school when I took neuroscience that it was kind of this window opened up in my head. And I said, this looks like something that I could really do something with. I found it fascinating. And I also knew that the brain was the kind of thing that over the course of my however many year career, there probably would still be exciting new things to do, and I wouldn't have figured it all out. So that was the main impetus to get started in this field.
No, it's all wonderful. I know that there's days when you just pour in your heart and soul into taking care of your patients, and you might be in surgery for even 14 or 15 hours. How do you endure the long hours that it requires for a neurosurgeon to have long surgeries and many surgeries back to back?
Well, yesterday was one of those days. I started in the OR at 7:30 and finished at 10:30 and got home after my whole family was asleep. So, it's one of those things that I think it's hard. You can train. That's why neurosurgery is a 7-year training program. We always kind of make that comment when things get tough. And we say, well, that's why it's 7 years to train to become a neurosurgeon after medical school. But I think part of it is just innate. I think it's just you either have the ability to kind of multitask and just focus. I'm one of those people where I don't care whether it's 3 hours or 20 hours, you just keep doing it. And then once it's over, I totally crash and think back and say, how could you have done that? But during it, you're just so focused on what you're doing, because what we do is so important and also so risky in some cases that if you can't have that level of focus where you put everything else out, then it's very tough to do. But that's not unique to neurosurgeons. I mean, imagine, police in the middle of the night when they get a call for something terrible, or soldiers in the field. There's a lot of people in our country who do the kind of work where other people's lives depend on them, and they have to stay focused for long periods of time under tough situations. And this is one of those fields. And I think that, fortunately, I think I have the ability to do it, although it does get tougher with passing years.
Well, thank you so much for fitting this webinar into your full schedule today. It's really special for us at the Essential Tremor Education Center and for our entire audience that you're taking time out to give us some lessons on essential tremor and to teach us. I've just brought up the agenda slide here now. And, as an audience, you folks can take a look here at what Dr. Caplet's going to be covering in the next 20 or 30 minutes. If you look at that agenda, you'll appreciate the fact that he's going to make a deep dive on helping us understand just what is essential tremor, and then what are the treatment options for essential tremor, and what is the newest treatment, what has the FDA most recently approved. And he's going to give us some appreciation for the NeuroVive technology and how that works, and how it might be useful even for some of you that are attending this webinar right now. Just to give you a perspective on the Essential Tremor Education Center, we work in behalf of 5 Alliance member sites nationwide. You see them pictured on this slide right here. They cover the corners of the nation from Florida to Washington to New York to Virginia and Baltimore. And these are 5 world-class organizations that are really delivering some of the best medicine in the world. These 5 organizations have come together through the work of our education center to advance an educational campaign across America in behalf of essential tremor. And we began this campaign in January, and here we are continuing. We've had over 100,000 people served so far through the Education Center in terms of the providing of information and content on this very important topic. Now, just to learn more about Dr. Caplet, who's going to be our presenter in just a moment, he is the Director of Movement Disorders and Pain at Weill Cornell Brain and Spine Center in New York City. You can see that he studied at Princeton, at the Rockefeller University. He was an investigator in the MRG-FUS trial. That's the clinical term for the Neurovive procedure. And so he has great depth on this particular topic and absolutely has his fingerprints on the available of this program to Americans that have essential tremor. You can see he's received quite a bit of distinction for his service in New York City as a top doctor, and he has been recognized in many venues and many forums, even appearing on the Charlie Rose Show with a patient telling the story about Neurovive and doing the same on a Dr. Oz physician panel. It's just wonderful that he can now take time with us to give us some meaningful lessons on this topic. Before I turn this over to him, though, I want to give you a call to action. There's something we want you to do for us this evening. On your screen, you should find a question and answer button that you could push, or a comment or chat button. And you know, during Dr. Caplet's message, feel free at any time to just drop us a message, ask a question. And you could even share a little bit about your life situation if you would like. We'd like to have you share your first name, what city and state you're from, and anything that you would want to express to us, please do, including a great question for Dr. Caplet. We saved a significant portion of time at the end of his speech to us for those questions to get asked. And so please start sending comments our way. And we'll look forward to your interaction on the question and answer button or your chat button. And now I'm planning to turn the screen over to Dr. Caplet, and he'll jump right into the important topic of our evening. Dr. Caplet, take it away.
Okay, thanks very much, Terry. So I'm really pleased to be here with everyone. I want to get right into it because I know that everybody's taking time out of their valuable schedules to listen to me talk about this. This is a subject that we're very passionate about here at Weill Cornell in New York, because we really feel that we now have an amazing new tool to help treat patients, specifically with essential tremor. But if we have time at the end to talk about, I think that the potential for this is enormous going forward, and that this is just the beginning of a whole new field of what we would refer to as non-invasive neurosurgery. I'm going to come back to that in a minute. Essential tremor itself is a disease that I assume many of you, if not most of you, are aware of. That's why you're here. It is a neurological condition. It usually is affecting the arms. That's where most people have the biggest problem, and it is a so-called action tremor. It's a tremor that occurs when you go to reach for something or use your hand or your arm. So when you're sitting there, for most people, unless it gets very severe or unless you have a tremor of your head or voice where it's more obvious, for a lot of people, you wouldn't know that they had this problem until they go to do something, drink a cup of coffee, write with their hand, do something else. And then it can be terribly disabling to the point where you can't use a spoon or a utensil without two hands, where you can't drink without either two hands or bringing your face towards the table to be able to drink, where you can't write at all. You have trouble doing other activities, as you see sort of represented here. And this becomes a major quality of life issue for a lot of people. And it's not just that a social stigma, although for a lot of patients that I see, particularly those that are still very active professionally and in other cases, it can be a terrible problem because they know that when they're in certain situations, the tremor is going to come out and be a problem. But it is also, as we said, a functional issue that can actually limit the ability to perform activities that are essential in life. And it is this vicious cycle because one of the things we know about essential tremor is that it can be made worse by being tired or by stress. Well, if the knowledge that you have essential tremor creates stress in certain situations where you know you're going to be asked to use your hands to eat at a restaurant table and it's going to come out and people are going to see it, then that adds stress to your life, and that's only going to make the tremor worse. So it's this terrible vicious cycle. And so it can be very debilitating. Now, the cause of essential tremor, the exact cause is unknown. It's not like something like Parkinson's disease, for example, where we know that there are certain cells in the brain that die in Parkinson's disease that make a chemical called dopamine and that creates those symptoms. In essential tremor, we don't know exactly why this starts, but we do know a lot about the disease. We know that it runs in families. It's not like an inherited disease to the level of something like cystic fibrosis or Tay-Sachs or whatever, where we know the exact genetic cause of the problem. But we do know that it runs in families. Many patients, about 50% of patients, will have, parents or siblings or aunts and uncles that are affected by this disease, often more than one. So they know that this is going to happen. And as a result, a lot of patients with severe essential tremor also worry about the next generation, about their children. Are they going to develop this? And that's a big concern for them. And we also know that once people have essential tremor, a big part of the problem is abnormalities in certain circuits in the brain that control stability, that control your ability to hold your arm or your hand in a stable condition and to move it smoothly without a disabling tremor. And so as a result of that, we have a very good idea of areas of the brain that are responsible for this problem, even though we don't know why it happens in the first place. In particular, there is a structure in the middle of the brain called the thalamus. Now, there's going to be an exam on this slide at the end, and Terry's going to pass that around to everybody, so you better listen to this slide very carefully. I'm just joking, of course, but even many of my residents don't know all the details of this slide, unfortunately. But there's an area deep in the brain called the thalamus, which is kind of a relay station. It's like the main train station or a hub of an airline where everything flies in there and then they fly out to all of the other places. In this case, the thalamus connects various structures in the brain to function better. And within the thalamus, on the right side, it's divided up into a lot of little areas. And one of them is called VIM. In this case here, it's referred to as VI in the sort of red portion of the thalamus. It's a small area that's in the middle of the circuitry that controls stability. So it receives connections from the back of the brain in an area called the cerebellum, which is responsible for coordination. And it goes, and then that goes through some areas in the base of the brain called the brainstem, an area called the red nucleus. That connects into this structure, VIM, in the thalamus, and then that goes up to the rest of the brain to help control smooth movements. And that becomes abnormal in patients with essential tremor, so it doesn't function properly. So when the rest of the brain says move, and there's a movement required, this area of the brain does not respond appropriately, responds abnormally. And it is that abnormal response that is a problem in essential tremor. And so how is that normally treated? Well, the first line therapy that most people use are drugs, and that's understandable. Nobody is going to rush to have brain surgery performed on them. I don't personally understand why everybody wouldn't want brain surgery, but it's, the fact is that most people will start with simple pills in their life, and that's fine with me. And those drugs are usually so-called beta blockers, which are designed as heart medication drugs. They are designed to slow down your pulse. They're designed to lower your blood pressure. They quiet down the autonomic nervous system, the adrenaline system in your body. It kind of opposes that. So it's not specific to the brain in any way. it just tries to quiet down the whole body. Similarly, people also use anti-seizure medicines because seizures are abnormal firing of certain areas of the brain, certain populations of nerve cells, and this quiets that down. So these are not targeted therapies that are designed specifically to treat essential tremor. These are therapies that were designed for other reasons and that are being used and in some cases abused to try to control the tremor. And it does work for some people. But for a lot of people, these drugs either fail to control the tremor to any meaningful degree, or they cause terrible side effects that you can imagine from what I just described. They can lower your blood pressure too much. They can lower your heart rate. They can make you dizzy, lightheaded. The seizure medicines can make it hard for you to concentrate, to drive an automobile with, and focus properly. It can make it hard to stay awake, etc. So for those patients with a disabling tremor, where it's very hard for them to function for the reasons I said earlier, and who are not receiving adequate benefit from medicines or who are having too many side effects, surgery is another option. Invasive surgery has historically been used to try to target this area of the brain, and I'm going to talk about that more in a second. But obviously, the idea of opening up the scalp, making a small hole in the skull, and then passing something through the brain into this target to either take that abnormally functioning structure out, to remove it or destroy it, or to put in a wire or an electrode that sends permanent electrical pulses in the body. Obviously, that carries certain risks of invasive surgery, which I'm going to talk about in a second. So back in the really old days, and I'm not talking about we're not talking about the prehistoric days, but back in the 50s up through around the 1980s, the surgeries for these things could be effective. They were invasive, but a probe would be passed through the brain, through a hole made in the skull. And then the brain would be probed, and you would try to figure out exactly where you were in the brain, and then heat up the area that was functioning abnormally, this VIM area of the brain, to try to destroy it, to essentially burn that small target. The problem was that it was not only invasive, where you were going through the brain, there could be some bleeding or other problems, but you weren't always exactly sure of how much you were doing to the brain, because there was really no way in those days of having feedback or knowing exactly what you were doing. You were kind of inferring what was going on using very primitive technologies. And so as a result, you could affect nearby areas of the brain, cause injury, permanent injury to areas that were unintended, that could cause permanent side effects that would be a real problem for patients. More recently, up until today, and throughout most of my nearly 20-year career doing this type of surgery, we've been doing so-called deep brain stimulation. That is a far superior therapy to what I talked about a minute ago, because we would put an electrode in the brain. We would have a better idea of where it was, because we could see before we turned it on with an MRI or a CAT scan after surgery. We could see exactly where it was before we turned it on. If it wasn't exactly perfectly placed, you could move it or adjust it. And it would send little electrical pulses through the brain that could help improve symptoms. And it's been very effective for patients with essential tremor, but it's been most widely used in recent years for Parkinson's disease. The issue with that, of course, is that you have to have a battery permanently placed inside your body like a pacemaker, attached to a wire that is permanently inside the brain. That has some risks of infection, etc. Again, it's invasive surgery, so there's some risks of bleeding in the brain as you pass the wire through. And there's still some risks that the electricity could, the effectiveness of the electricity could be limited by spread to nearby structures, although that is reversible. Another option is to use radiation. That is totally non-invasive. But the issue with radiation is that you are, of course, radiating the brain, and there are some risks of radiation in terms of cancer formation, etc. And the area of the brain that you're targeting, you cannot see immediately what's happening with radiation. You are relying on the radiation, on the brain to have a reaction to the radiation and die off over time. So you target an area with radiation, and then you're hoping that over the next 2 or 3 months, that what will die off is exactly what you want and not what you don't want. but you really don't have control at the time of the radiation for what happens. So if it turns out to be not as precise as you had hoped, there's no real way to know that or adjust that over time. You only see the consequence long term, and then whatever the consequence is permanent, but it is non-invasive. So there clearly was a need and has been a need in all of neurosurgery, but particularly for essential tremor, for a safe and very accurate therapy that is non-invasive, that does not involve leaving devices in the body, that does not involve the risk of penetrating the brain, and that gives you immediate real-time feedback as to what you're doing so that the patient can respond directly to you, so you can see whether or not you're improving their tremor right there at the moment. And you can see on the MRI right there at the moment exactly what you're doing, so you can adjust accordingly to get what you want and not get what you don't want. And that's what we have here with the so-called MR-guided focused ultrasound. So the principle behind that is very similar to what many of us did as children with when you would take a magnifying glass, and on a nice sunny day, you could put a leaf or a piece of paper on the ground, and you take that magnifying glass, and if you focus the sun's rays just right through the magnifying glass, you could create enough energy on the leaf or on the piece of paper to actually burn a hole in it and maybe even start a fire. The reason for that is that when the sun's rays come down, their energy, any given beam of sunlight is not particularly problematic for us. But if you can concentrate a whole bunch of beams of sunlight onto a single point, such as focusing it with a magnifying glass on a point on a piece of paper, on a leaf, then you can add up all of those beams, as you see here on the upper left of your screen where that little fire is. You can see these three separate beams that are parallel to one another, now all being redirected towards the one spot on the leaf. And that's exactly what we're doing with the ultrasound. Most people are surprised to see that ultrasound waves can actually go through the human skull. The problem is that they're very unfocused. They get very scattered as they go through the skull into the brain. And the genius of what this device can do is that it is a helmet of 1,000 sources of ultrasound. I don't know if they chose that on purpose because, for many of us of a certain age, we remember George Bush's 1,000 points of light, but it's exactly 1,000 sources of ultrasound energy. And all those 1,000 sources focus, just like this magnifying glass analogy, they focus on the one spot in the brain that we're interested in this case, that target that I mentioned earlier, the so-called VIM. So these different sources are all angled so that they can intersect and add up their energy only at that one spot that you can see, that red spot on the upper right side of your screen. So any given beam of ultrasound as it goes through the brain is relatively safe. We all know that for decades, when women are pregnant, they will have ultrasounds of the fetus, and the ultrasound energy goes through the fetal brain and it causes no problem. Some women with high-risk pregnancies can have these ultrasounds on almost a daily basis and there's no problem. And we know that the developing brain is more sensitive to problems than the adult brain, and yet the ultrasound is perfectly safe. So the individual beams of ultrasound as they go through the brain are fairly safe, but the machine allows them to converge and add their energy up at the specific spot without causing any damage or injury to the brain tissue that they go through. They only cause a change at the spot that they're focused on, and that's it. That's what allows us to non-invasively eliminate this abnormally functioning spot in the brain without affecting the rest of the brain, without invasive surgery. And so this slide simply reiterates what I just said, that you get this focus of ultrasound energy right on that spot. And when we hit the spot just right, we can then increase the amount of energy that's delivered progressively and slowly, so that we go from a low level of energy that does not cause a permanent change to make sure we're in the right spot. And then as we slowly increase the amount of energy delivered, we get feedback from the patient telling us how they're feeling, telling us if they're having any strange sensations, any trouble speaking, any numbness anywhere, any difficulty moving. And as we're talking to them continuously, we're also seeing what's going on the MRI screen itself, so we can adjust accordingly, make sure we're in the right spot, and then deliver more and more energy until we see on the table the tremor stop, and then we make it permanent, and then the patient is done. And in our center, the patients go home an hour after the procedure, which would never happen with invasive surgery. I've never sent anybody home an hour later. So the way the process works is the patient is put into this frame. I'll talk about that in a second, that holds the head in place. And then, because we can't have the head move, obviously, you can't have a device with this degree of precision and then have people get up and move around anytime they want. So we have to keep the head fixed so that it doesn't move during the procedure. And then we lower this helmet that has this array of ultrasound sources on it. The so-called transducers that you see below are the sources of ultrasound. And then the helmet gets filled with cool water, because just like the jelly that they put on the ultrasound when you're getting an ultrasound of a baby, ultrasound does not go through the air as well as it does through liquid. So we fill up the helmet with cool water, actually. And then we can measure the temperature rise in the brain. So as we deliver more and more energy, you can see a spot, a red spot with the temperature increasing as we try to take that spot out. And then we can actually test the patient, as I said, in real time. Why is the next slide not going? How do I get off this? Okay. So as we said, so one of the things that some people find initially a little off-putting is that we do have to shave the entire head for this procedure, because even the hair follicles, the little stubble of hair, can affect the ultrasound and its efficiency. But I've not seen anybody yet that it doesn't grow back on. And some of my women patients who had long hair have actually decided to keep their hair short long after this procedure. So it's actually, for some people, given them a whole new hairstyle and a whole new personality, but that's not because of what we did to their brain. And then we put this frame on under local anesthesia. So we actually fix this device to the head to keep the head from moving. Then we do some images to plan to make sure we're in the right spot. And you can see here that the little sort of set of circles in the middle of this MRI, in the middle image, is the spot we would be interested in. And then we send a low level of energy in there to confirm that we're in the right place, and to see whether usually we see about 50% improvement in the tremor when we're in the right spot before we make it permanent, so that we have time and the ability to adjust things if it's not perfect before we've done anything that's permanent. And then when we're sure we're in the right spot and not having any problems, then we increase the amount of energy to a temperature level to raise that temperature up, and we can see it happening in real time to try to eliminate that spot, and we see the tremor go away on the procedure table, on the MRI table. And so this gives you an example of one of our patients. This is before their treatment, trying to write a spiral on the left side or trying to draw a straight line. This is how bad this patient was. And this is right at the end of the procedure. And you can see this dramatic improvement. And this is, by the way, in the MRI machine with this frame still fixed to their head, writing upside down, probably with one of those space pens that you can write upside down with that they talked about on Seinfeld or something. But you can see that the dramatic improvement. And then the other thing that I can show you here is how precise this is. So in this patient, you can see before the procedure, the two spots on the right and left side of the brain that we're interested in are in green here. We can actually map out the specific connections in the brain using modern brain mapping technologies to see exactly the connection that we want to hit. In this case, it's in green. The areas right nearby in yellow behind it are the connections that control sensation, that if we hurt, it could make people numb. And the area immediately outside the green that's in red control movement. And so if we hit that, it could affect your speech, it could make your arm weak, etc. So we don't want to hit that. And what you see here is that before the procedure, they've got all of these three structures on both sides of the brain. But afterwards, on the right side of the screen, you see that the green is gone, and there's a little sort of light round shadow that you can see, which is the destroyed area of the brain, because the rest of the normal brain in that area is much darker. But you can see a little light cloud where the green was. That's the actual destruction that we can see. And yet we've totally left alone the red and the yellow part. This is actually from a publication in a major international journal that we have coming out on how we're using this brain mapping to do this, but it gives you an idea of exactly how precise this can be. This is some data from the New England Journal of Medicine article on the study that Terry mentioned a while ago. It's a recent article actually that shows the long-term follow-up. And you can see how the patients improved as a group. So a higher score means worse tremors. So you can see here that their tremors improved dramatically. Somebody with no tremor would have a 0 score. Now you say here, well, this doesn't look as dramatic as the picture I just showed you, and that is true. And that was actually one of the sort of criticisms among certain circles of this paper, even though the results were impressive enough to get into the New England Journal of Medicine, was that, well, is this really enough of an improvement? And I can tell you that part of this is because this included a lot of patients over a number of years. It wasn't over a short period of time. And I think that the results using advances in some of the technology and the knowledge that we found, I think the results have gotten much better over time, frankly. Our experience has been that most patients have had between an 85 and 100% tremor control after this procedure. But the other thing is that it also depends on how bad the tremor is, right? The patient that I showed you, their tremor was so bad that it's easy to tell that they had about a 90–95% improvement in their tremor. But there are some patients where their tremor is not as severe as that, and so you improve them, but numerically it doesn't seem as bad when you improve them, even though for them, that degree of improvement was plenty because you took them from sort of mild or moderate tremor, which was annoying them enough to want a procedure, to being less than that, and now they really don't have much of a problem, even though the numbers didn't show an enormous shift. So the worse you are, the more you're going to see a huge shift in numbers, and that's part of what's affecting this as well. But nonetheless, you can see a really nice improvement, and it's sustainable over the course of at least a year. And you can see here on other scales how disabled they are, right? So patients, the higher the score, the more disabled you feel on ratings. So you can see that the disability improved dramatically. It lowered dramatically in the patients with the treatment, and that stayed over time and not in patients who underwent sham. And these are examples of how much they improved. So in this case, higher is better. 100% improvement would be it's gone. And you can see how much they improved. And finally, you can also see, again, a variety of other rating scores. This is this Quest score is just sort of a rating scale, and they did better on that. And then these are sort of activities of daily living, how they feel about hobbies, about physical activities, psychosocial stress, etc. Psychosocial thing is interesting because you can see how much it's reduced the stress that people have when they're in social conditions because they feel that it's improved them enough that it's made that better. These are some of the side effects people have had. There have been, to my knowledge, no significant bleeding effects from this. In theory, even though you're not going through the brain, there's a slight risk that when you actually destroy a spot of the brain, you could cause a little bit of bleeding, but nobody's actually seen that. And we've been comfortable enough to be able to send people home the same day if their post-procedure scan looks clean, and we've not had a problem doing that. You know, some patients have a few other issues, such as some discomfort in the head. That's normal because you're putting this box on their head and you're sending all this energy through. Some patients experience some dizziness or some nausea. We have found that there's a pill that we can give patients that can pretty much eliminate that. And so we've not had that be a big problem in our center, and more centers are now using that. So the dizziness, the nausea, and vomiting are less of an issue, scalp tingling, etc. This is during the treatment. So and then these are side effects following the procedure. And so in this New England Journal study, you see mild, moderate, and severe side effects. And the most common is a mild gait disturbance, a balance issue, which is not surprising because I told you that this area is involved in controlling coordination and balance. And so it's not surprising that almost half of the patients, or a little more than a third of patients, experience this problem. But it's fairly mild. And in our experience, it's been similar. It's been about half of our patients, and it seems to resolve usually within a day or two to at most 3 weeks. Mild weakness that seems to have fully resolved. We've not seen much of that, frankly. It may be because of this advanced targeting we're seeing, but it has been seen in some cases, but not as a permanent problem. And then headaches, it's understandable when you had this box put on your head and you had this thing done that some people might get some headaches. And then a very small number of patients with some mild speech things that seem to resolve. But we haven't seen anything yet that's major. There have been, in our experience, we've had a couple of patients that have had a bit of worsening of their tremor after a few months or a few weeks or months of having near complete control of their tremor. And that's always hard to gauge when you've done enough versus too much. But the vast majority of our patients, like the New England Journal study, have had stability of their tremor now out to a year. And we're hoping for longer-term follow-up to see, as time goes on, how stable it is. One of the things you have to realize is, as a newer procedure, we can't tell you whether this is going to be stable for 5 years or 10 years, but there are patients from the very earliest treatments that are now getting into that 3 or 4 year range. And so we will be generating more of that data over time. But at least it does seem in most patients to be stable for at least a year. And in my experience in neurosurgery, a year usually means longer than that. So to summarize, you're talking about a procedure that allows great accuracy with great precision at a sub-millimeter level, that gives us real-time feedback, both in terms of the patient responses and of what's going on the MRI, with only local anesthesia needed, no incisions, no invasion of the brain, very low risk of infection or bleeding because you're not penetrating the brain, you're not leaving any device in the body. You get real-time feedback. This is FDA approved as of the fall, and you get this immediate effect where patients can go home the same day. We've treated several patients in their 80s and one patient in their 90s, and they all went home within an hour of the procedure. So this is something also that we think expands opportunities, particularly for older patients, but we've also had some very young patients who've gone back to work because of this. And so we do think that this can make a major difference in quality of life. Obviously, you have to talk with us or with anybody else that you'd want the procedure with about more details about this. I don't want to imply that there's no risk at all. I've talked about that a bit, but we've been extraordinarily happy having done this as an invasive procedure for 17 years. I've been quite amazed at how well tolerated this is and how remarkable this is for the patients and how much they've really loved this. And so with that, I'm going to kick it back to Terry.
Thank you, Dr. Caplet. Enjoyed your sense of humor from time to time there during your presentation. With the 1950s being important to me, I was a little unnerved when you used the prehistoric term in relationship to that decade. In any case, it all was very meaningful, and we're grateful for the content you shared. When it comes to this fascinating technology, there's good news and bad news in terms of how it all works for us in our community of essential tremor. Good news is the technology is amazing, and it absolutely does everything that Dr. Caplet has just talked about. And we're watching patients all across this nation enjoying the benefit of that. The unfortunate bad news is that Medicare and the health insurance community tends to run behind the FDA. And there's a multi-year delay with government and insurance coverage. Upshot is this is a self-pay technology. And so folks that are stepping up to receive this treatment are doing so because they just see wonderful quality of life benefit, and the benefit outweighs the price. They view this as maybe even a priceless benefit, and they're stepping forward all across the country to receive the benefit. But unfortunately for now, it is a self-pay therapy, a self-pay procedure. For folks that want to be kept aware of health plan access or Medicare access, we do have a way to put your name on information list and keep you posted on progress that we're receiving here at the Education Center. In fact, I'll put up a slide right now that gives you a phone number that you can call, a way to reach us online through the tremoreducation.com website. And you can get information about pricing for you. It does vary by individual and by site. And so, we can help you sort out what the cost would be if you wanted to have this procedure soon. If in fact you're in a situation where that just is not an option for you, but you want to stay aware of Medicare or insurance coverage, We'll include your information on our database to keep you posted on that as well. Our Tremor Education site cares about every individual, no matter what your situation is. We want to get good information to you so that you're most aware of these circumstances. Now, at this time, we're going to get back to Dr. Caplet, and we have gotten a whole bunch of questions. There are a couple hundred folks in our audience here, Dr. Caplet, and they must be quite intrigued by your message, because we've just gotten a whole bunch of questions. We're not going to be able to get to all of them with you.
I can hear it all ringing in my ears.
I'm going to start working through some of these personal questions and give you a chance to respond to our audience members. The first individual says, I'm 43 years old, and right now my tremors are very mild. However, I assume that my tremors will worsen as I age. Is it better to get treated now or wait until my tremors are worse?
Yeah, that's an outstanding question. We don't have a perfect answer to that, but I'll give you my personal opinion. I think that it really depends on how mild and how disabling it is to you. The one thing about this treatment, as you can see from some of those pictures that I showed earlier, is that it is much easier for us to be sure that we've done a good job when you have a more severe tremor. If the tremor is very mild, seeing the difference between a very mild shake on those spirals, or on a straight line versus no shake can be a little bit difficult. And so we do need a certain amount of tremor to be sure we've done enough with the procedure to actually be of value to you and be sustainable. Otherwise, we're kind of guessing a bit. Now, we have treated a few patients with more mild tremors successfully who just felt that it was bad enough to be a problem for them. But I would say personally that as much as I would love to help everybody and treat everybody on the planet if they wanted to come to me, because this is what I do, I think that if it's really very mild and it's not causing any problems in your life, you're not having any limitations on anything, then I would not necessarily jump to this right now, because you don't know how much worse it's going to get. Everybody's different. Some people get worse fairly quickly. Some people, it can take decades. So you don't know where things are going to go over time. And we also are still learning some about the longevity of this effect. So if it's really severe or even mild or moderate but causing problems in your life, then I can help you make your life better now. But if I can't help you make your life better now, then I can't say with all honesty how long this effect is going to last, even though I think it will last for many years. And I would rather not waste that at a time where it's not affecting the quality of your life.
Hey, thank you, Dr. Caplet. The next question was actually requested from two different individuals. A gentleman by the name of John from Colorado, and also a physician from Kentucky sent in the same question. And the question is asking you to compare Gamma Knife with focused ultrasound, and to get back to the question around how safe is Gamma Knife really?
Right. So one of my residents is a neurosurgeon in Kentucky, so I hope it's not him throwing in a ringer, but one of my former residents. Let me put it this way. I'm not here to sort of try to be negative about other treatments. I still do a lot of these things myself as they come up. The only thing I will say about Gamma Knife is that Gamma Knife is a procedure that is primarily used for cancers, to try to send targeted radiation to kill cancer cells. It is used for certain types of non-cancer diseases like facial pain, so-called trigeminal neuralgia, and people have used it for essential tremor, as I said earlier. The reason I've never personally been a big fan of that is because, number one, as I said earlier, the biggest problem I have is you do not get immediate feedback that you're in the right spot. What you do with Gamma Knife is you target an area of the brain, and then you tell the radiation source, go to this area. And it does something similar. It has an array of a bunch of radiation sources that send a low grade of radiation energy through the brain that all then add up their radiation energy in the circle that you draw, or in the area that you're interested in. So it's similar to ultrasound in that regard, except because of the nature of how the radiation affects essential tremor, it doesn't immediately kill that area that you're interested in. It takes time. So what you do with Gamma Knife is you put the patient in the machine, you pick the spot on the brain that you think is the VIM, that you think is the best spot, you radiate that, and then you basically hope for the best. Now, I'm not suggesting that it has an enormous, complication rate where they hurt 50% of their patients or something. Otherwise, it wouldn't be out there. I don't want to be, I don't want to say things that are untrue about any of this. But for me personally, as a functional neurosurgeon whose job it is to try to improve brain function and try to target very specific circuits in the brain with great accuracy to try to normalize functions in the brain and make people better, I am not terribly comfortable with targeting structures and having no feedback from the patient, no feedback from the brain itself on MRI or anything else, and just sort of assume that I'm in the right spot. I know from my long experience operating inside the brain of patients that the target that I think is the right target is usually the right thing, but it's not always the right spot. And we often will have to move it by a millimeter or 2 or 3 in one direction or another to get it just right. And I've known that for many years. And with brain stimulation, we do that by penetrating and probing the brain. But with this non-invasive procedure, we do that by seeing exactly on the MRI what we're affecting relative to what we want, and by seeing what the patient's responses are and putting all that together to say, are we where we want to be, or do we need to move a little bit? You cannot do that with Gamma Knife. You just target what you think is the best spot and then hope for the best. And to me, these are procedures that should work nearly all the time. They may not work exactly all the time. I don't want to be quoted ever anywhere saying that anything works 100% of the time, but they should work frequently enough that they should work more reliably than almost anything else in neurosurgery if you choose the right patient and you hit it just right. That's why I prefer a procedure like this that's both non-invasive and highly accurate with feedback that tells me I'm where I want to be.
Next question is from John, and John lives in Houston, and he wants to know if essential tremor affects balance.
Right, so that's a great question. And the answer is there is some evidence that it does, but it's not proven. So, Terry, I think we're still on you, but it does. We have had some patients that have balance problems before the procedure. As I mentioned, patients can have some transient, temporary balance problems after the procedure, but that goes away. But we have had some patients, and I've seen this for many years in my brain stimulation practice and my invasive surgical practice, some patients that can have some balance problems beforehand. So it's possible. Many of us have the impression that the more severe the tremor is, the more likely you are to have some other problems like this, but it's still not entirely known, but it is possible.
Okay. Now, Greta wants to know if she can get the Neurovive treatment if she has AFib and is on blood thinners.
That is a really great question. So that is one area that has been a challenge here. The answer is basically no, because I think over time that may change, but the concern about staying on blood thinners through the procedure is that there is still some theoretical risk that when we destroy that area immediately, that you could, have a tiny little microscopic blood vessel open up and cause a little bit of bleeding. That wouldn't ordinarily be a big problem, but if you're on blood thinners, then it would keep bleeding and bleeding and be a problem. We've not seen that very much at all anywhere in the world, to my knowledge. But I just don't think we've done it long enough to be comfortable with that. What we can do, though, is most patients with atrial fibrillation can temporarily come off of their blood thinners. And so it really depends on your disease. But what I will say is that compared to invasive surgery, we can very likely start the blood thinners. And I've had this situation before with the ultrasound where we've taken a patient off their blood thinners for AFib, done the procedure, and then started them pretty much again the next day or the day after because we're so comfortable that everything is fine, where I'm a little less comfortable with that with more invasive procedures. So It's not that we can't do it. It's just that if you're on blood thinners to a degree where they simply cannot be stopped even for a day or two, then that would be a bit of a concern.
Okay, so John is indicating that he's had ET, essential tremor, for more than 20 years, and it's just getting worse and worse. And so it's a very difficult situation. He inherited it from his father, and he's wondering why the Neurovive treatment is only approved for treatment on one side.
Yeah, that's a great question. So, and that's something that I'm actually working on addressing as soon as we hang up from this webinar, because we are actually working with the company. There's 3 centers that are working with the company to try to develop a study right now to do the second side on patients who've had the first side done. The reason for that is that if you remember the slide I showed early on that showed the important structures that are right next to it, the thing in red in particular, that red connection that was right next to the green that we want to take out, that red area controls speech and it controls movement to some degree. And there was some evidence from the older procedures that were done in the 50s, 60s, 70s, where you would burn that spot or destroy it invasively. There was some evidence that when you did it on both sides of the brain, patients could have higher rates of complications than when you only did it on one side, meaning that they would have a higher occurrence of speech problems, some occasional memory problems, etc. And we're not entirely sure why. There is some belief that it's because it was a less precise procedure and you didn't know exactly what you were doing at the time to the brain, that we were affecting those nearby areas in red more than we would now with a more precise procedure. That was the belief at the time. That's one of the possibilities. But there is also the possibility that the brain just tolerates taking out this one circuit on one side of the brain well, and as long as the other side is there, it can continue to support certain things. But if we were to take out that other side, then you might still have a problem, even if it's more precise. That's something we just don't know exactly yet. That is why we are working on a study to try to answer that question, because so many of our patients that we've already treated and so many patients that want this procedure ask about this, because after we treat one side successfully, then it makes the untreated side even more prominent for that patient. And even if we treat the hand that you write with and drink with, etc., the so-called non-dominant side becomes even more annoying to them than it was before, because now they see what life could be like with no tremor. Also, patients who have tremor in their head or in their voice, often you need to do both sides of the brain to control that. So there are a lot of reasons why we want to do this. This is something in great demand, but we've got to do it properly and study it so that we understand it to keep people safe, which is the first priority that we always have.
4 members of the audience have asked the question, is there a risk of a stroke when receiving this procedure?
Right. The answer is sort of no with a qualification. And what I'll say with that is there is nothing that I am aware of in how this technology works, nor is there anything that I'm aware of from any of the patients treated worldwide. And it's approaching, to my knowledge, almost 1,000 patients now worldwide who've had something done with the focused ultrasound. I am not aware of anyone having a stroke. It's possible that it happened and I'm not aware of it, and I'm not aware of it, but that's my understanding. And I don't know of a mechanism of how this works that could cause a stroke. As I said, there is a slight risk of bleeding that's different, but a stroke, meaning that you have a blockage that would kill an area of brain, I'm not aware of a mechanism how this would do that. In fact, there's some experiments going on about trying to actually use the ultrasound to treat stroke, to break up clots using the ultrasound. So that's actually being studied and could wind up at some point in patients. Having said that, with any procedure that's new, that involves doing anything in the brain, I will never say with 100% certainty that you can't have anything. Anything could theoretically happen. But I think within the realm of what we consider reasonable, I don't see much of a possibility of this causing a stroke specifically.
So David would like for you to talk a little bit more about side effects like speech loss. He said, I went to see a movement disorder specialist who discouraged me from pursuing this strategy because of high risk of speech loss. Could you speak about that a little bit?
Right. Well, the data just doesn't bear that out. I mean, I understand why people might say that because they're concerned about those areas that I was talking about that are nearby. First of all, I'm not aware of any patient that's had speech loss. Okay, we've had one or two patients that have had some issues with their speech where it sounds a little more like they're slurring, you know, a little bit like for some period of time after the procedure. In only one case did it last for more than a few days, and the other case, I think, was just briefly following the procedure. Because one of the things you have to understand is there's a distinction between what happens that's permanent from the procedure and some temporary things that can happen for a few days or a couple of weeks after. Many of the temporary things are because after you destroy that small spot in the brain that you want to hit, the tissue around the brain can react and you can get a bit of swelling. Imagine, for example, if you bang your hand and it hurts a little bit and then you go to sleep. And then the next day it blows up and becomes all purple and swollen and everything. The body will develop swelling around any area of injury, usually 24 to 48 hours after that injury. And in this case, we are sort of eliminating or injuring that very tiny spot in the brain. So there often is a little bit of swelling around it. And that swelling can happen a day or two later and take a few days to a couple of weeks to fully resolve. So when patients are doing fine at the end of the procedure, but then they develop something like some numbness or some speech slurring or something a day or two later, that's usually from that swelling, and then that resolves over time, and that's been our experience. But so far, just like in the study where you saw that there were only 4% of patients, which is not by any means a high risk, 4%, who had only a mild speech disturbance. And in our case, so far, it's been something that's been fairly temporary. I wouldn't consider that a huge risk. It's a risk. We talk about that with patients, just like there's a risk of any other surgery, just like there's a risk with brain stimulation surgery that you could have a bleed and die from that because of inserting the electrode. But that's not a very high risk, and I wouldn't consider that a high risk for brain stimulation. It is a risk. Here, there is a very low risk of a mild speech problem, but I'm not aware of anybody worldwide having speech loss where they can't talk after the procedure. And I'm not aware of many patients where it hasn't pretty much fully resolved.
So here's your last question. We're going to wrap up after this one. George is concerned about eligibility. He'd like to give consideration to doing a Neurovive procedure, but he has learned that skull density is a significant variable in determining his eligibility. And he wants to know how he can resolve whether his skull density would make him eligible or not. What is the method for his learning his eligibility relative to skull density?
Right, so that's a very sophisticated question. Let me start the answer real quick by just explaining for everybody else who may not be aware of this what he means by that. So the ultrasound, as I said, has to go through the skull. And it's a little bit counterintuitive. Most people would think that if your skull is too thick or too dense, that the ultrasound might not go through, which is actually not true. I'll say parenthetically that when we measure the skull density, people's spouses often want to know whether they really have as thick or as hard a skull as they've always believed that they have, whether they're as hard-headed as they always believed it. And I can tell you, I once thought about doing a study to see whether patients' skull thickness really relates to their personality and their stubbornness, but I haven't really had time to do that study yet. But what we do to determine whether you're a good candidate is we actually do a simple CAT scan. It's a 2-minute non-contrast CT scan. You go in the scanner, you come out, and then we have that scan analyzed. And this is through a special software package from the company. So we have to send off the CT scan, and they will measure the density, the firmness of the skull. And about 10% of patients, unfortunately, will not be good candidates for this treatment, not because their skull is too firm, but the opposite, because it's too soft. That seems, like I say, not obvious to people, but the reason for that is that as the ultrasound tries to go through the skull, if it's too soft, then the bone marrow and the liquid in the skull will actually absorb the ultrasound. And it makes it much harder to get enough energy into the brain. It's like if you scream into a pillow and your sound gets muffled and absorbed by the pillow, it won't get through. And so the ultrasound actually goes through a firm skull better than it does through a soft skull, where it kind of gets absorbed and it's hard for us to generate enough energy to make the procedure. It affects about 10% of patients. We've had a couple of patients that we've screened that have not been good candidates for this because of it. We've ultimately done brain stimulation on those patients who've done well, because that's obviously still an option for them. And so that is an issue. The way that we analyze it for most patients is they come to visit us, and then we get a CAT scan here and send it off to the company. But we've had some patients that we have treated who come from out of town, and to try to make things better for them and facilitate things, we've tried to identify imaging facilities locally that we can work with, usually at a university center where we know somebody that we can work with, to generate the right kind of scan, because it has to be done a certain way, but it can be done on any CT scanner. It just has to be done a certain way. And then it gets sent to us and we send it off to the company. And if then you're a good candidate, then it makes it easier for you to decide whether or not you want to come to us to actually get the treatment.
Dr. Caplet, your thoughts this evening have been really meaningful. You've shared a lot of fascinating insights. We're very grateful for your taking the time to do this with our audience. Before we get ready to sign off and review the communication information here for reaching educators, is there any last thought you'd like to share with the audience?
Yeah, well, I just want to thank everybody for joining us. Obviously, we're here, and the Essential Tremor Education Center is here to help anybody who we'd like to help. If you have any questions, just call them or reach out to us either way. And I really appreciate everything. Hope everybody has a good night. And I hope my lengthy answers will help you sleep better tonight and put you to sleep. So thanks for joining us.
It's likely to impact our dreams. So yes, thank you. And thanks to every one of you for being with us. You can see on the screen here our phone number at the Education Center, our website address. Please visit us, chat with our educators. We're here to assist you in any way that we possibly can. We'll leave this screen up for a few minutes if you need to copy any of this information. But yes, please have a good night. And thank you again, Dr. Caplet. Everyone take care. Bye-bye.